cross-section partnerships for our movement to ensure everyone has what they need to be healthy and thrive. We have a chance to learn about the potential for public health to work with community power building organizations and advance advocacy around health and equity. And we'll hear about how the city of Buffalo has made health equity a high priority and benefited from multi-sectorial collaborations. So if we could go to the next slide. So anyone who hasn't joined us in the past couple of months, we want to just remind everyone that we have recently changed our name for the Alliance for Disease Prevention and Response to the Alliance for the Public's Health. And as we have transitioned our work to focus on transforming our public health system, better integrating cross-sectorial and community partners, and advancing equity, we believe this name better represents our broad and inclusive focus. Now, August is when school starts in many, and it's when we celebrate National Immunization Awareness Month and highlight the importance of vaccination for people of all ages. So I want us to work together to promote the importance of vaccination and encouraging people to talk to a healthcare provider that they trust about staying up to date on their vaccinations. So lastly, we hope many of you will be able to join us at the APHA exam meeting in Minneapolis this October. This year's theme is Building Trust in Public Health and Science. And we have many sessions relevant to this topic and the work of the Alliance and our members. So we'll spend more time next month. So go to the next slide. So now I want to introduce the panelists and then turn it over to Glenda to moderate. And now we're ready to turn to our panel discussion about opportunities to better integrate and learn from communities and cross-sectorial partners in our movement to ensure that everyone has what they need to be healthy and thrive. We have some extraordinary panelists. We have Glenda Young Marquise, who's our moderator. Glenda is a seasoned professional with extensive experience in risk management, public health, and government affairs. She specializes in integrating the psychosocial environmental models and has a holistic approach to optimize public health programming and ensure operational continuity. She's currently at NATRO, or focuses on addressing health inequities exacerbated by the COVID-19 pandemic. Our other panelist is Clara Long. Clara is an attorney. She's the Director of Policy and Organizing of Human Impact Partners. She's responsible for developing and implementing Human Impact Partners' overall strategy for policy, advocacy, organizing, and research in support of social movement partners. She's a human rights lawyer and uses strategies in research and advocacy, which contribute to campaigns to abolish an immigration detention center in which people were dying because of medical neglect. Claire, thank you very much for the work that you've done. A third person is Matta Frey. Matta is, after working in the field of public health evaluation and research and philanthropy for over a decade, Maddie started a public health evaluation firm in 2018 to provide consultative services for organizations who are learning evaluative thinking and tools and movement towards systems change. She's got prior work at the Cottage Health Hospital Director of Population Health Evaluation in Santa Barbara, California. She served as a Healthcare Georgia Foundation Director of Evaluation and worked with the Center for Community Health and Evaluation in Seattle, Washington. And then the final panelist is Pastor George Nichols. Pastor Nichols is CEO of the Buffalo Center for Health Equity and the senior pastor of Lincoln Memorial United Methodist Church. He's a member of the Community Foundation of Greater Buffalo's Racial Equity Roundtable, a convener of the Concerned Clergy Coalition of Western New York, and chair of the African American Health Disparities Task Force. So with that, I'm going to turn it over to you, Glenda.
Thank you very much for that introduction. Hello, all. My name is Glenda Young Marquez. I am a senior program analyst with NACHO's Health Equity and Social Justice team. And today I'm thrilled to be here with you as we dive into a vital topic: lessons from community collaborations. As we work towards advancing health equity, we know that building strong collaborations with our communities is not just beneficial, it's essential. Our panelists today bring a wealth of diverse experience and insights that will illuminate how working together in our communities can spark real transformative change. Get ready to be inspired and empowered as we dive into incredible impact that collective action can have on creating healthier and equitable communities. So let's get started and explore the power of community partnerships in shaping this future. I'm going to go ahead and pass it on to our first presenters from Human Impact Partners, Maddie Frey and Clara Long.
Thank you so much, Glenda. I believe Maddie Fry will be sharing the slides. Thank you so much, Maddie. Great. Well, we really appreciate being here. And just as a clarification, Maddie, we've been so privileged to have Maddie Fry working with us with Human Impact Partners for this work. So though we have different institutional affiliations, we're a team. And I'm going to kick us off and just give you a few framing thoughts about this work that we've been doing on community power building groups and public health non-governmental organizations to understand how we can better reimagine public health advocacy. So Maddie, if you could advance me, I appreciate it. Thank you. Let me tell you just a bit first about Human Impact Partners. The goal of Human Impact Partners is to transform the field of public health to center equity and build collective power with social justice movements. We do that through three main houses: the policy and organizing team, which I lead, a team that's focused on bridging partnerships and strategies, really bringing in a cohort model health departments into deep relationship with community power building organizations, which we're going to talk a little bit more about in the next few minutes. CPBOs, community power building organizations, that is. And then our capacity building team, which some on this call, I think you, Glenda, have had a lot of contact with. And the capacity building team is working, as the name says, directly with many in the public health field to build the capacity to center equity. So that's HIP, as we call ourselves. Maddie, if you could move forward. HIP's theory of change is based on the idea that community power and building community power is central to making sustainable change. And we define community power as the ability of communities most impacted by structural inequity to develop, sustain, and grow an organized base of people who act together with democratic structures to set agendas, shift public discourse, influence who make decisions, and cultivate ongoing relationships of mutual accountability with decision makers that change systems and advance health equity, taken from this great Lead Local glossary that I totally recommend if you haven't checked it out. And what that means is that we prioritize working with community power building organizations. And I want to make a distinction here, one that is sometimes blurry on the edges, as many distinctions, but a distinction between community organizations or grassroots organizations necessarily, although those words are sometimes used interchangeably, as this slide points out, but organizations that support base building are doing the work to bring people together in a way that increases their power. And they can do that around a geography, like a neighborhood or a city or a state, a demography or an identity, like youth, workers, people who are or have been incarcerated, or around an issue like workers' rights or environmental justice. And I have here some logos of some of the organizations that do this, that we work with: People's Action, Faith in Action, Jobs of Justice, the Rights to the City Alliance, CPD, the Center for Popular Democracy. So can we go to the next slide, please, Maddie? So where we're starting in this work that we're about to talk about, which begins with a set of observations, is, as I described in the prior slide, we need community power to achieve health equity. and we need to directly engage in social determinants policy change. And who's doing policy change? Well, a lot of national community organizing groups and local community power building organizations. They're doing policy change and strong advocacy. And if public health joined with them, we potentially have a lot to bring. We have strong infrastructure to draw on, tons of data, many values aligned practitioners. But HIP's observation has been that cross-movement relationships, relationships between public health and this world that I've just been describing of social movement organizations and power building organizations who are doing the advocacy, are weak and underdeveloped. And so we undertook a landscape scan, or actually 2 landscape scans, where we tried to understand what it would take for, and in this case, we really focused on the non-governmental public health world, to build relationships with and provide advocacy support to. There's that.
Because I'm not as cool as.
There's that acronym again, community power building organizations, CPBOs, and the wider social justice movements they lead. And we did this over last fall and the winter and spring. We started with doing interviews with national community power building networks, 13 of them, to discuss what they knew about public health, what they wanted to, what experiences they had, what they hoped to see, how they thought public health could be helpful in their efforts. And then we spoke with 22 non-governmental public health organizations as well. We to ask what kind of advocacy they were doing and what kind of relationships they had with power building groups and where they could see themselves moving. And we did an analysis, developed some key takeaways, themes, identified key findings, and Maddie, here's just a quick list of our organizing network interviews. And Maddie, if you can go forward. And then a list of our non-governmental public health interviews. Thank you for those of you who are on this call and participated. We really appreciate it. So we're going to move now to tell you, Maddie's going to tell you a little bit about the main findings from this scan, which you can also find in a health affairs article that I'll drop into the chat. And then I'll come back to tell you a little bit about what we're doing next. Go ahead, Maddie. Thank you so much.
Thanks, Clara. And hello, everyone. Again, my name is Maddie Fry, again with Fry Evaluation, partnering with HIP in this project. So we had several key findings from both the sets of interviews that we pulled together. And so these findings represent both sets of interviews. And the first finding is that, as you can see here, many of the groups we spoke with were not deeply familiar with community power building efforts in public health. Despite, in some cases, their familiarity with the idea that power imbalances are the root cause of health inequities. They were also unfamiliar with the national community power building organizations and networks who are leaders of social justice movements, even though, again, these movements often win changes that very significantly impact the public's health. So making these connections and growing this understanding in the public health community will make it much more likely for public health organizations to invest in community power building and social justice movements. And the quote you see here from one of our interviewees, within the field of public health, there really isn't a robust understanding of power. And that's really what this quote gets at. And I almost said next slide, but I'm talking to myself. Our second finding is that, we learned that many CPBOs understand their work and goals as deeply tied to public health. So from economic security, labor issues, climate justice, criminalization, and many, many more. And some also made the direct connections between power building, policy change, and health outcomes. Several interviewees even named the health benefits of the act of organizing itself. But many still had a lot of questions about the who and the what of partnering at an organizational and sectoral level with public health entities. Among those who did really understand or have experience with public health organizations centering the social determinants, we heard we want more of that. We need more of that. and a desire among many for guidance and partnership to tell the story of their work in that health frame using those public health frameworks. And I want to point out the third quote here in particular. While our organization is not an expert on public health, it is the reason our communities are organizing. Oops, let me go back one. All right. So our third finding is really about the advocacy tactics that are being used. And I just got off a call talking about this, so I'm happy to dive deep into it. So when we interviewed non-governmental public health organizations, we shared with them a summary of what we had heard from the power building groups. Specifically, that these power building groups were requesting from public health various advocacy tactics. And here we found a lot of alignment. So in general, power building organizations really recognized public health's value and strength with data, reports, and research, and shared a strong need for this. And conversely, providing data and reports was the #1 advocacy tactic that public health organizations shared that they are already doing and feel most comfortable doing. So both groups of interviewees shared that it's really the lack of relationships is the reason that they aren't connecting more with each other already, even though there's this clear alignment. Relatedly, despite the lack of relationships, our fourth finding is that power building organizations really want greater public health support and advocacy for their campaigns and members. The few partnerships that they have had have been resoundingly positive and strategic and added value to their campaigns. And these groups would like deeper collaboration and support for their campaigns and members, and would like to see a bolder sectoral presence at the national level from public health. This quote really shows that, there are all kinds of things that people who are impacted know, but it's so helpful when public health people come and give us data and scientific backing. This is truly what is needed by power building groups from public health. Next, we learned that public health and community power building organizations are truly facing the same threats. So many national community organizing networks and CPBOs understand deeply the attacks on the field of public health as tied to the same policies and structures that they are working to transform. So this includes the rise of authoritarianism and embedded attacks on the public sector at large. And they see public health as playing an important and needed role in pushing back on these forces. So in order for the CPPOs to take action to defend public health, they shared that they would need a better understanding of public health as focused on systems change, policy level work with explicit ties to their agendas around the social and political determinants of health. And as that last quote there says, there is potential alignment there, but would have to be clarity about how public health organizations are supporting the causes our members are fighting for. How do we clarify the interconnection? And then lastly, a clear theme emerging from the interviews was the need for a coordinated ecosystem for public health and power building groups. And here there was certainly a range. So some participants expressed high interest and readiness to get involved. That was about half of the group. And then some were supportive, but waiting to see what their role might be or if the focus aligns with their organization's mission. And that was a little less than half of the group. And then there was a small group of organizations who were either uninterested or just didn't have the capacity right now. And a current barrier to involvement is still just this lack of clarity. And public health organizations shared they want clarity on the goals and what their role would be, what is being requested of them from CPBOs, and how can they get involved in a way that actually helps and doesn't harm. And I want to read both these quotes. One, we need more coordination because we are all trying to swim in the same direction, but we don't know what each other are doing. And then secondly, so much of how effective we can be in working with CPBOs is about relationships and trust. And having a coordinated approach might lead to more consistency in how non-governmental public health partners show up. That consistency is what's needed to build the trust. I'll let you read that. And if you remember nothing else from our presentation, our big takeaway from this landscape scan was that public health has what power building organizations want in the form of data and reports, but in other forms too. and that power building organizations also have what public health needs in the form of advocacy and movements that are making a real impact on the public's health, on the social determinants of health. But what's truly missing is the relationship between the two. There are a few, but they're not coordinated, and it's not around a common goal. There's huge alignment here and huge potential. So Clara, I will turn it back over to you.
Great, thank you so much, Maggie. Where do we go from here? We are forming a coalition, an organized body of non-governmental public health organizations. We envision a public health ecosystem that can strategically advocate for the policy priorities, as Maggie said, many of which are shared with public health, of community power building organizations and networks. We think that this coalition can contribute to that ecosystem by merging our voices together, building the capacity of member organizations and others, and concretely engaging with our voice and our power in alignment with social justice campaigns and movements. Through doing this, we envision the transformation and strengthening of the political, social, environmental, and economic drivers of health equity and racial justice, and that we will build a bigger we as part of movements to achieve that transformation. I want to say this coalition will launch in the next couple of months. Our name is the Public Health for Community Power Coalition. If you would like to learn more about how to be involved, we'd welcome you to get in touch. I'll put my email in the chat, and Maddie, maybe you can too. That concludes our part of the presentation. And we're looking forward to the discussion.
Thank you so much, Clara and Maddie, for that great presentation. I just want to remind everybody, you'll have opportunities to ask questions at the end. So if you want to drop questions into the chat, please feel free. We'll log them and be able to ask our awesome panelists at the end. So now for another perspective on community collaborations, I'm going to pass it off to Pastor George Nicholas, the CEO of the Buffalo Center for Health Equity.
Thank you so much, Glenda, and good afternoon to all of you. And thank you to my colleagues, Clara and Maddie, for an excellent presentation. My name is Pastor George Nicholas, and I have the honor and privilege of being the Chief Executive Officer of the Buffalo Center for Health Equity. And I just want to kind of briefly give you an overview of who we are and what we're doing, and just kind of give some insight on how I think we can help our communities better. The Buffalo Center for Health Equity, we're unapologetic about who we are. We're community driven. We're committed to structural change. You must address the root causes. We are trying to change narratives, cultivate inclusivity, and raising consciousness. And we are unapologetic about the issues of race, and unapologetic about the central focus of our advocacy is to eliminate race-based health disparities in the city of Buffalo. That picture there is a recent picture of partnership, an award that we've gotten from the National Institute of Health in partnership with the Jacobs School of Medicine at the University of Buffalo. And you'll see there in that picture, along with myself, you'll see our local Congress member, the dean of the medical school, the majority leader of the New York State Senate, the director of the Erie County Office of Health Equity, and also the director of the CTS-SI at the University of Buffalo. Next slide, please. And how did we get to this point? Next slide, please. So back maybe about 2014, we began having a conversation, and the we was a very small group of us in community around health disparities in the African-American community. And we forged a journey and created what we call the African-American Health Disparities Task Force. And out of that task force, which was initially just really a few community members, we reached out to the University of Buffalo and some other partners at Erie County Medical Center and others uh, to think about how do we change the narrative? How do we make a public statement about here in Buffalo? This is what it looks like in terms of the health outcomes for African Americans, and how great a difference there is between blacks and whites in terms of chronic diseases and health outcomes. Out of that, we created what we call the Igniting Hope Conference, where we had a major conference that was attended by over 300 people or so, and it was at the Jacobs School of Medicine. And why is that significant? The Jacobs School of Medicine really uninvitingly impinged upon a black neighborhood to build this very beautiful but in some ways obtrusive edifice that really disrupted the fabric of a black neighborhood on the east side of Buffalo. And obviously that created a great deal of tension, and many folks had vowed to never set foot into this institution. But it was our perspective of, even though the university did some tremendous missteps on this, the institution was there, the university is there, and the university can and must and should and has an obligation to be a positive partner in addressing the issues of health disparities and moving towards health equity. And so we invited them to be part of this thing, and we said, let's have our first conference right there in the medical school. And it was, quite frankly, it was the first community activity that was ever done in that institute. And it was well attended by not only certainly people within the institution of the university, but people within the community. Out of this conference, we birthed birthed three important organizations and that are having an impact on health outcomes in the city of Buffalo. One is the Buffalo Center for Health Equity, which is a community-based organization, which I am the CEO of. And our focus is on research, policy, community engagement, neighborhood development, and advocacy. And so that organization is really been a leader and cutting edge on changing the narratives of what and why there are such great disparities around health outcomes. Two, the University of Buffalo created the Community Research Institute, which is embedded in the university. That singular focus is to address the issues around health equity within the city of Buffalo. Recently was funded with received a $10 million endowed share. And so this is something that is going to be part of the fabric of the University of Buffalo. And then two is the Erie County Department of Health Equity. Following COVID, and Erie County, which is our health department, was a great partner with the community on what we called the COVID-19 project that we reached out to almost every Black person on the east side of Buffalo, which was in our region, and we were able to reduce the fatality rates of African Americans in our county to be in alignment with the population rate. So as you know, across the country, African Americans were dying about 2.5 to 3 times the population rates within their geographic areas. Because of the work of our COVID response team, where we engaged about 10 or 12 different churches, community-based organizations, and others, giving out information, providing food, giving access to vaccines, and getting access to masks and other things that people needed in order to survive through COVID. We were able to have a really big impact on our community. Out of that, we created what we would call the Erie County Department of Health Equity, which by county law is going to be embedded in county government, and with its focus to address the issues of health equity. And so all three of these entities work together. I'm the CEO of the Buffalo Center. I'm chair of both the other committees, organizations, but we all work very closely together in collaboration. And I use that word collaboration in our understanding of collaboration. It must produce something, right? If the collaboration does not produce something that's going to impact the lives of the people who you're trying to help, then you're just having a get together, right? And so we have been able to show that from our initial work as a task force, we've been able to produce three very important institutions within the city of Buffalo that work in concert with one another to begin to address the issues of health equity within our community. Next slide, please. What does it sort of look like? Here is a really, and excuse for the small print, but we centered health equity, and then these are just a sampling of all the different people that are at the table right now working on this issue with us. From health insurance companies like Highmark and Independent Health, the university, the county, the Urban League, the Buffalo Bills Foundation, Rite Aid Foundation, and then or community-based organizations like Harvest House, which provides direct services for people within the community. And so we have them all around a series of tables, not just one table, but doing the work that will impact health outcomes for people within this community. And you can take the slide down. I'll just talk to folks for a couple of minutes before we go into some questions. And so it's our belief that we cannot achieve health equity unless we directly impact the root causes of what's driving the inequity. It's our belief that we have to address issues around education, economics, housing, and we're working in collaboration on a major demonstration project to transform the housing stock within a distressed community, that we have to give people access to primary care and access to food. This cannot happen in isolation. If community-based organizations could do that on their own, they would do it, right? If advocacy groups or activists could do this stuff, they would do it. It's clear that the only pathway to true transformation is equitable partnerships with community-based organizations who are out there on the front lines, living the experience and doing the work, and also institutions that have power, resources, and the means to really impact things. So institutions like universities and like government, they have to be at the table. Now it's difficult because past history, many of these institutions have been, just steeped in structural and systemic racism. Many of these institutions have neglected their responsibilities to poor Black and brown communities. But we cannot let that past history block us from engaging new partnerships and new relationships moving forward so that we can solve the problem. And I'll finish with this because I want to leave time for our questions, because I know many of you have questions. With collaborations, they can no longer be just transactional. We cannot just collaborate because there's a funding opportunity out there, and the institution says, "Oh, I need a community partner on this, so let me call this group," and so I can trick the NIH or the CDC or Robert Wood Johnson and make them believe that I have an authentic partnership with this community group. No, the relationships have to be transformative, and a transformative relationship is not driven by just responding to an RFP, right? But it's working together in collaboration when there's no money out there, but that you're using whatever resources that you have at hand right now to begin to work on these problems. And I liken it to this. In the Rodgers and Hammerstein film, The King and I, and one of the great songs out of that, when you had, if you can recall, the teacher was trying to begin teaching, but there was no relationship there, right? That and you can't really do work unless you build relationship. You can't produce anything unless you build relationship. And many of you will recall that song, Getting to Know You, right? Right? And getting to know all about you, right? And and that's how our mindset has to be, right? That institutions, community-based organizations, if we're serious about producing better health outcomes in our communities, then we must invest the time into getting to know each other and beginning to build relationships with one another. So then when it comes time to do work with one another, we're not working with a stranger, but we're working with someone that we know. So we spent a lot of time in building relationships, and we continue to build relationships with partners in corporate America and block clubs and whatever. And it's working fairly well for us. It's a work in progress, but you always have to invest the time. It's that balancing act of addressing things with a sense of urgency, but also investing in the time of building relationship. I'll stop there because I want to give my colleagues and others and the rest of you opportunity to engage in a dialogue with us. And I thank you for listening.
Thank you so much, Pastor George. So we're going to get started with our panel discussion here. If everybody wants to give our awesome panelists a round of applause digitally, we'd certainly appreciate it. We really appreciate all of your insights today. Pastor George, as you were talking, I was thinking about something we typically use at NACCHO, talking about an ecosystem of health, as opposed to one person being in charge of health, and how we can use that to achieve health equity and social justice in our communities. So I want to talk about your experience in working with public health collaborators and what was different in their approach in working with you as an organization and working towards achieving health equity?
Well, I think the different approaches. One is we were clear on what we wanted, right? And so we believe that your ethnicity, race, and location should not be a central determining factor in your health outcomes, right? So we don't settle for just progress. I mean, we celebrate progress, but our goal is equity. And two, we have a better understanding of what people can do. So if you want to be engaged with an institution like a university, like government, like an insurance company, understand what they can do, right? Understand. Don't ask someone that's selling ice cream to provide hot dogs for you. Understand what is it they can do, and then ask them for that and demand that. And when you understand what they can do, it's very difficult for them to deny you. Right? It's very difficult for them to say, well, we don't do this or whatever. And one of the early conversations that we had with the university and trying to bring them into the relationship is they invested in this thing called the Global Health Initiative, right? And I think that's good. I think it's very important. But I had to point out to them that the east side of Buffalo is certainly, if you had a globe, you would find the east side of Buffalo on that globe, right? And so if you're truly concerned about global health, then you have to be concerned about the issues that you see just looking outside of the window of your office, right? And so that helped them understand that, okay, yeah, we can. That's what we can do this, and so that's very important. And then three is be driven by what you're trying to accomplish, and not driven by the money you're trying to get. Right, right. What are you trying to accomplish? And if you understand those things, then it'll give you a better understanding of the resources, the money that you need in order to move forward.
Yes, thank you for bringing up that last part there, that our end goals are really important, and having value-based partnerships as maybe opposed to funding-based partnerships, as you highlighted. Now, I want to ask the entire panel, because I believe this is my $4 billion question of the month, which is, if you were to build a health department from scratch, what kind of community supports would you build into the foundation of that health community? And we can even open that up a little bit broader to say into that public health organization. Whoever wants to go first.
Go ahead, Claire, and then I'll jump in after you guys.
My mute finger is slow because, as was said in my introduction, I am a human rights lawyer who came into public health 3 years ago. And yet, I will say that, excuse me for the noise, but Human Impact Partners has developed a resource over many years, and that we're actually, we'll be releasing an update of, called the Health Equity Guide, which presents a set of strategic practices to confront power imbalances and forms of oppression, which we see again as the root of health inequities, and has a lot of very specific answers to that question. What would you build in to a health department? It is these relationships, it is the capacity to shift power dynamics, which again is based on how well you tend to the relationships that that are the most important for changing power. And I see this question in the chat about how do you turnover proof those relationships? And I think that's identifying a key challenge, which is which you have to address perhaps in a multi-pronged way, having relationships that are institutional, that span multiple staff members, that are baked into a sense of shared values. Seem like ways to start answering that question. I'll turn over to another panelist to say more.
Sure, Maddie? Okay. Well, I think what I would think is to make sure that we clearly understand what are the things that drive health outcomes, right? And to not have stuff be so centered on what's happening inside of the healthcare system, but making sure that we understand all the things that are happening in community that impact the health of individuals, and making sure there's a clear connection between health department and economic development department, the educational department, the housing department. Like, all of these things have to work in concert with one another, and that the institutions or the governmental institutions must begin to start framing investments through a health equity lens. And what do I mean by that? If you're going to, like, for example, here in Buffalo, we're spending this ungodly amount of money on building a football stadium, but it wouldn't be so bad if the investment was done through a health equity lens. So, okay, if we're going to spend this money, how will this money be used to address some of the social determinants of health, like jobs and economic development, housing, or whatever that can impact the health outcomes of poor communities. So that's how I would kind of frame it.
I have 30-second response because I don't have a ton to add. This is more from my evaluator hat, which is that I often see health equity just like slapped onto the end of a theory of change or the end of a logic model, and then we'll get health equity. And it just drives me crazy. And I see it in some public health frameworks too, like equity is just slapped into the middle of the 10 essentials. Equity, we'll do it through an equity lens. I'm like, but you haven't changed anything. How? Why? What's different about your activities? What's different about how we're showing up as human beings? What's different about the priorities, what's different about, are we actually addressing root causes? So that would be my response to your amazing question, Glenda, is like, what is our theory of change, and kind of recentering, like restarting the whole thing with equity at the center.
Yeah, I definitely agree with you, Maddie. And thank you all for your thoughtful answers on that. I kind of want to throw an additional question in here. Can you all give us your personal perspective on what a health equity lens truly is?
Understanding how the inequalities and all the things that operate around us impact the health outcomes of all of us, right? And it just to be prioritized and defined and be made clear that this is something important to us within our communities.
Thank you for that.
Yep, I totally agree. I mean, we know that we all deserve to have the best outcomes, regardless of who we are. And so for me, it comes down to kind of, are we addressing kind of the root causes of where those inequities are coming from? Or are we still kind of on the surface? And then are we engaging people who are most impacted in the process, such that it sort of flips it, like we engage is almost problematic. So it's like, who's leading the effort? And then how, again, like, how are we showing up? Are we showing up with our full selves? Are we creating inclusive environments? Are we able to deal with conflict when it comes up? Not if it comes up, but when it comes up. So to me, an equity lens is sort of across all of those components.
Thank you very much. And we're going to be wrapping up this discussion a little bit in just a minute. So
I want to answer Oscar. Yes, the School of Public Health is involved with our work. Yes, very much so.
thank you very much for that. So we have one last question, and then I'll ask, and we'll get to your hand raise, Oscar, in just a second. I just want to ask a really quick question, and this is sometimes just kind of a very superficial kind of response you can give, but what is one recommendation people can take today to ensure equity in their relationships with community?
I would say, most importantly, understand power structures. Examine how institutions, policies, social norms are being shaped by those in power and how they perpetuate or structure power. And understand how you fit in. Where are you sitting in all of those structures? And from that self-reflection and analysis, engage in authentic relationship, so that you're putting yourself in a position to truly challenge and redistribute power, which, as Maddie just said to this health equity lens question, is the root cause of health inequities. That's my.
It's important for us, I think, to see the humanity in the people that we're on the table with, and even that an individual who may represent a system that may not be practicing health equity, don't project that upon the individual that's at the table, and try to make that connection so that that person may feel empowered to move their institution or their system to be more fully engaged, right? But don't be dismissive of a person just because of where they work, and prevent yourself from making a human connection with someone that may very well want to be a partner in this work, and we just got to kind of help them figure out how they can do it.
Yeah. I get the advantage of having y'all go first. Those were great answers. I would say equity can sometimes feel so insurmountable, especially inequity. And like, well, what can I possibly do in this moment? And yeah, the humanizing aspect, Pastor George, is so important. And just, I would say, to see yourself as making a difference in these what might be perceived as small interactions, but actually aren't small, are actually incredibly important.
Excellent. Thank you all so much. We're going to open.
Real quickly, and fight against the cynicism of the past, you know, because trust me, at the beginning of this journey, so many quote unquote community folks told me, oh, I don't know why you waste your time with the UB, why you waste your time with the county, why you waste your time with this one and that one. And I get it, because history teaches us a lot, but don't let that lock you, right? So just don't be just driven by the cynicism of the past. Be hopeful and optimistic, and believe it, and believe that you have the ability to change it.
Thank you so much. And thank you, Pastor George, for that reminder. It was a great reminder in our pre-meeting too. I want to open it up to questions. And Oscar, I have seen your hand up, and I want to hand it over to you to answer or ask your question to the panel.
Thank you. Can you hear me?
Yes, we can.
Great. I appreciate it. And thank you for such a terrific panel and conversation. I will have to caveat, and I'll be very quick, Pastor. I actually went to UB, and I spent a lot of time in Langston Hughes, so I totally understand the historical aspect, especially with racism, et cetera, and the fruit belt. And of course, we're seeing now with Buffalo and UB being a major investor in real estate down in those marginalized communities. So my question starts with you, but of course has the ability to flex across the panel. When we think about the movers and shakers, the community power building organizations, the power aspect, or say the leveraging of public health around this topic of health equity, we're also seeing this pushback, this melding of DEIA with health equity. Folks wanted to step away from, quote unquote, addressing issues of equity, especially from a business perspective. Are there opportunities that you see, whether we call them the commercial determinants of health or not, to really get commitment, not only from the partners that we know, but from those commercial and other entities who have a role to play and an impact on those determinants of health, that we really need to be at the table and to be consistent with their commitment?
Yeah, I mean, that's a functional relationship. I mean, I spend most of my time building relationships and with people who historically may not be engaged in this kind of work, right? And just constantly reminding them of the responsibilities and opportunities to bring change, to be and also to have an understanding of the economic argument. I was in a meeting this morning about it, and I mean, there's an economic argument for equity as well, right? And so to be able to articulate those things, and just to not be discouraged, you know, and just stay at the table, because that's one of the things that happens is if things don't happen as quickly as we want them to be, or if things don't align like we think they would, it's so easy to walk away. And I'm just one of those type of people that I'm going to not walk away, and I'm going to hold you accountable, and I'm going to say, hey, this is something we can do together. And so, you know, maybe that's not as clear as the answer, but I can only speak from my own experience and how I think a lot of it has to do with leadership too, you know.
Clara, did you have anything? I can take a stab at it. So I tend to be a both and person, like almost to a fault, probably to a fault. And the commercial determinants of health, I've never heard that term. Thank you for educating me. So on the one hand, I think, well, probably not. Like, corporate America is responsible for a lot of the health inequities we're seeing. And I'm not sure what it would look like to walk hand in hand. On the other hand, we do have some examples, of where companies, socially minded companies, have made a huge impact. And I think those are the companies that didn't just hire the chief diversity officer and then fire them 2 years later. Those are the ones who maybe had thought about racial inequities already and were already working towards change. So I think it's a both and I think, I of course am asking sort of who is showing up to those meetings, who's being invited to those meetings, is tokenism happening? Those are the kinds of questions that would come up for me.
I can answer from a campaigner's perspective, which is what I am, and that is that that a good corporate campaign always engages with companies. It always engages in a negotiation and a dialogue and a relationship. It engages also in how do we gather power to make change, but no change maker is off the table, and that there's a lot that we don't want to leave opportunities for improvements, concrete improvements in people's lives off the table either, and that requires relationship and negotiation. So from one other perspective, I see some other folks unmuting now.
Thank you all so very much. We really hit on a topic that we could talk for days and days and days. So wanting to thank you all, thank our panelists, Pastor George, Clara, and Maddie for joining us today, and also for the Alliance for opening up this space to have this conversation. Until we meet again.
Thank you.
Back off.
Yeah, and I just want to thank our panelists again. As you all heard, this is a really amazing discussion. I know I had a lot of lessons that I pulled out, and I think as we all think about how we're going to bring together new partners from community, from different sectors, such important, different but related perspectives that I think Glenda was able to help us pull out. So thank you, Glenda, Clara, Maddie, and Pastor George. I know we learned from all of you, and thanks to the group for joining us. If there are any examples you'd like to share, things you've worked on, questions you're dealing with, please drop them in the chat or email us at alliance@apha.org, and we will make sure everybody gets them. Otherwise, have a great rest of the summer, and we will talk to you all at our next meeting in September. And thanks to everybody.
Thank you, everyone.